So whoops. All right. So thanks for having us this afternoon. As Linda mentioned, my name is Jenna, and I serve as a pharmacist by training and as a medication safety officer here at our hospital, as well as providing leadership to our second victim support program. And I work with various teams amongst our hospital looking at patient harm and adverse drug events. We were really continuing to see the impact on our frontline staff when doing that process. And so it's really how we got started, and we'll tell you a little bit about our story in a moment, but just wanted to throw it also over to Brandon. Do you want to do a quick introduction for yourself as well?
Yeah, sure. So hello, everyone, and formally a good afternoon for everyone here on East Coast time. As Jenna said, I'm Brandon Kozar, and I'm a psychologist by training and background, and I currently serve as the director of our You Matter staff support program, which we'll be telling you all about here in a little bit more shortly. So thank you, Jenna.
All right, so the objectives of our presentation today is we hope to be able to go through an overview of the lived experience of clinicians in the aftermath after an unanticipated event. We'll go through some of our different supportive strategies that we have put in place to support our individuals, and then talk about ways to keep the momentum of a support program, and talk about some of the expansion that we've done from our second victim peer support program to really expanding it to various other models, which Brandon will go through later on in the presentation. So just to share a little bit about my story, oftentimes people ask me, how did you get involved in this work? And I was a resident at Nationwide Children's several years ago, and during the first few months of my residency as a new pharmacist, I was involved in a medication error when working in our IV room. And I was preparing a factor product at the time, and it ended up leading to a 10-fold underdose to a patient. I was very lucky that there was no harm to the patient, but I'll never forget the support that was given to me after that experience from one of my peers that had been at Nationwide for over 20 years. And I'll never forget Roger. He came to me after and talked to me, provided support, shared experiences that he had in his past. And one of my first thoughts at that moment was, I wonder if everybody gets this level of support from their peers. And at the time, we had nothing formal in place. So about 2 years after that incident, I joined the medication safety team. I was new to the role in medication safety. And so I was often during my daily work following up with frontline staff that had been involved in medication errors. I'll never forget the conversations that I had with people when I first started my career. Hearing the words of, I can't sleep at night. I don't know if I want to be a pharmacist anymore. I'm afraid I'm going to go to jail if I make an error. There were things that really just kept coming forward. And as a group and team of medication safety, we kept thinking, how are we going to better support our staff at our institution? And so, as Linda alluded to, I work very closely with my dear friend and mentor, Sue Scott. And at that time, years ago, a few of our nurses in our quality department actually attended an IHI conference where they heard Sue speaking about this topic. And when they returned from that, they shared that information with me, and along with the group that I was working with, we said, let's have that connection. Let's have that call with Sue. And she provided us such help in really starting and getting our program off the ground, for which we will forever be grateful to her for. So when we think about, the initial terminology of second victim, Albert Wu was one of the first to come up with this term, really talking about, those who suffer emotionally when the care that they provide ends up leading to patient harm. So, directly involved in that medication, some type of error. But that definition really got further expanded in 2010. In 2010 to really include healthcare providers, not only just involved in unanticipated adverse events or medical error or injuries, but really anyone that has been traumatized in some way while working in healthcare. So today when we talk to you, we don't just want you to think about only the individuals directly involved in an error, but really try to think about those that might just are dealing with traumatic situations, like maybe a nurse that's on the floor that's had a patient get verbally or physically aggressive with them. Or maybe it's the brand new medical resident that's in the ED and just experienced their first level 1 trauma that had a negative outcome, though everything was done correctly. So really thinking kind of broadly about that definition and who can be impacted. So when we looked at ISMP came out with a safety alert on the suffering of second victims back in 2011, and they talked about second victims can suffer a medical emergency that's the equivalent of post-traumatic stress disorder. I know I myself remember every single time I checked product for months after my error, I remember having shakes and really being nervous. And so I definitely don't think that that people are alone in that. In this issue, they also talked about that the instant that patient harm occurs, that involved practitioner also ends up becoming a patient of the organization, but one that is often neglected. So we would often reach out to people following events, try to be that supportive structure for them, but we just didn't have the capacity to do it at an institution of our size where we have 14,000 employees. So we knew we needed to do something. So we turned to the literature. We looked at studies that, surveyed out their faculty and staff and said, how, in this one particular study, they looked at, how many individuals had actually heard of the term second victim, 39%, how many experienced maybe personal problems within the past 12 months. So maybe after following an event like this, so having that feelings of anxiety or depression, or really even questioning their ability to perform their job. And 15% said they just contemplated leaving their profession as a whole. Whereas other studies looked more specifically in other areas, like a group of surgeons that were surveyed, 7,900, and around 6% said that they had suicidal ideation that was associated with a medical error. It was twice the rate of the general population at that time. Whereas 28% of a group of physicians said that when they were involved in an ADE, 17% of those individuals said it significantly impacted their personal life. We often hear this from our frontline staff, that it is so hard to leave this type of situation at work, and it does follow people home into their personal lives. And then last, a study looked at pediatricians that had dealt and cared for patients after death, and they said that they 100% felt the need for some level of emotional support. Whereas I'm sure many of you may be familiar with the story of a nurse that ended up committing suicide due to a medication error. This nurse was a very seasoned nurse that was involved in a mathematical error that led to the overdose with calcium chloride, causing the death of an infant. This nurse was very seasoned, had been a nurse for almost 30 years. But after that event, she was terminated from her job, had fines to be paid, put on probation, and lack of support. And really, we ended up with having two tragedies out of one tragedy. And so I'll never forget when I was presenting this at a neonatology conference, I remember a woman walking up to me afterwards a few years ago and said, thanks so much that there are people out there talking about this type of work, because this was actually my friend and my colleague, and I was the one that caught that error that day. And she was very tearful in nature, but it just brought it into such reality that we hear about stories like this, but oftentimes think that can't happen here, or that won't happen here. But we all need to be prepared for situations like this to happen. And how are we going to support that clinician or non-clinician in instances like this to prevent a second tragedy? Eric Kropp was a pharmacist that had also, around experience with IV admixtures, but was involved in the overdose of a sodium chloride that led to a death of a child. Eric ended up having his license permanently revoked and had a slew of different, as you could see there, fines to pay and issues that he had to encounter. And, Eric now talks about how he wishes he would have had some level of support following the darkest moments of his life as well. And so we turn to say, okay, who out there is doing this? Where do we even start when we started to think about, because we knew that we had a need, but we were trying to figure out where do we go from here, and who has these rapid response systems in place. And we turned to a lot of the work that Sue Scott did at that time. They had studies of talking about really understanding the second victim experience to develop these rapid support structures. In their work, they had interviewed a group of providers to really understand that suffering experience from the initial experience all the way through the healing interventions. And they came up with and published on the 6 different recovery stages of these individuals. And so when we think about the second victim recovery trajectory, it really makes a lot of sense. And I encourage you all to think about maybe experiences that you've had, starting off with that initial chaotic kind of accident response. So in that moment, individuals are also often thinking, how did this happen? And taking care of the patient or trying to figure out which teams need to be notified. In stage 2, individuals get to that point where, they're replaying the event. What could I have done to prevent that from occurring previously? In stage 3, the restoring personal integrity. So, individuals might be questioning, when I walk into work tomorrow, is my colleague going to trust me to administer meds to that patient after I was just involved in this large medication error the day before? And sometimes at this point, people get to some, people may not say anything to this individual, which could create some potential isolation by not having anybody to talk to. Stage 4, folks would, think about that and during the inquisition. So, am I going to have to go through litigation, or am I going to have to go through an RCA, things of that nature, lose my license? But in stage 5, people get to that obtaining emotional first aid, but oftentimes they don't know where it feels safe to obtain that emotional first aid from or who to go to. And then at the stage 6, it's more of that moving on point. So a lot of times these people end up becoming maybe the patient safety advocates, or wanting to be a peer supporter, wanting to make sure, that they are providing support to individuals. Others end up in that surviving mode. So maybe they're able to continue in their daily work, but the minute that a 4-year-old with, brown hair comes in, again, it might bring up all the same feelings of an event that they were involved with. And that last stage is dropping out. So how do we think about people and be able to provide them support before they get to the point of leaving their profession? So being able, this also highlighted on being able to, identify individuals, have a formal support structure in place, and really having a support network that's easily to access. So if we don't have an accessible network in healthcare, we need to have something not only during daytime hours. This needs to be robust in the sense that we're a 24/7 operation. And how do we facilitate that? This was something else, these next few slides, that were very helpful for us because we were given a lot of pushback initially on the startup of this program, mainly because we were told we have an employee assistant program. We're already helping our staff. We have this in place. And we went back to say, hey, look at studies like this, where they looked at where people wanted that emotional support from, whereas 35% said they wanted that from a peer or colleague, manager or supervisor, people that understand the daily work that they're doing, maybe have been through that situation, just like me. The pharmacist made a similar error that I had made when they were working at one point. And then you can see how it drops into those other categories. But this was the one that really helped sell to our senior leadership, because we were able to say, look, that 83% of the time people want support internally. It's not that we don't extremely value our EAP program and working with our professionals. We do, and there's absolutely reason when we need to escalate into that. But 1% of the time people solely wanted the external support. Then you can see the breakdown, but that large percent of the time people really cared to have peer support. So we were able to start a program, and it was largely worked in collaboration with Sue early on to really model the model that they developed, that Scott 3-tiered interventional model of support, where that tier 1 model was at the local and unit level. So we really went around to various different, manager meetings and meetings around the organization, talking about second victim support, what it is, how each of us could play a role in this, kind of raising that awareness. Whereas tier 2, we started training peer supporters. So we have a robust training program that then allows people to provide that one-on-one mentoring and team debriefings. But we also still very much value our tier 3, which is an expedited referral network to our professionals. So Brandon, as used to be a large part of our EAP program. before joining us on our team here at Nationwide, we worked together so closely because we were able to get people that quick assistance to professional help when they needed it. So if you're a more visual person, again, kind of that event could happen, utilizing that Scott three-tiered model of support to help facilitate interventions to hopefully move our recovery into more of that thriving and surviving zone versus dropping out. So we had all that info, and we were at that point of where do we go for developing this? So we decided to benchmark against that initial study that I discussed earlier on in the presentation, and we did it in pharmacy. So this pilot started in pharmacy. And with that, we had over 80% of our staff had actually heard of second victim, but a similar amount said they experienced problems in the past 12 months. And 13% of our technicians and pharmacists said that they contemplated leaving Nationwide Children's. We asked if they felt that this would be valuable to have a program to support individuals, and largely it was answered with yes. So we created the You Matter team, and this team provides support 24 hours a day, 7 days a week. It was created really to raise awareness of that second victim phenomenon, deliver guidance and support, and have these resources to people that they could effectively utilize. Our team from day one, we took a slightly different approach than some other programs, was that we wanted this not to just be a program for doctors or just for nurses, or, it was for everybody. It was for our interpreters that are delivering really difficult news in our emergency department. It was also for our environmental service workers that are cleaning those rooms after a multiple trauma. It really, we have peer supporters from all of those different areas, which I think has really led to the strength of our program, and sending the message to our staff that everyone matters. Everybody working in a healthcare environment could experience some level of trauma. So we didn't want a one size fits all on how you can access our program. So we have badge buddies that let people know that they're peer supporters. There's a phone line. We have email groups, stuff on our intranet, but there's a variety of different ways people can access support to our program. We've continued to work and publish because we want to get this information out to help other institutions start programs. You can see some of the key components in one of our publications in Pediatric Quality and Safety that talks about, the importance of finding an executive sponsor, building a core team. We had no funding when we started for years. We were, I say, grassroots movement, literally people around a table that had a passion and safety and to support their colleagues and coworkers. And that is where we started. It's not where we are now, which you'll hear from Brandon in a moment, but it is where we started. And then just kind of some of the other different teams that we think are important to engage. So where we started initially with piloting this in our small department in 2013, you can see we've now grown to having one of the largest peer support networks and programs in the country. I'm going to show you a quick video and then turn it over to Brandon.
I work in the emergency department, and I see a lot of traumas and experience a lot of bad situations.
You internalize a lot of the things you've seen, and I always wondered kind of where it went.
My worst day as a pharmacist was during a trauma. I was responding, preparing medications for a patient, and we thought this patient had potentially a really bad adverse reaction to a drug that I had prepared.
You have to consider the amount of pressure you're under. IV stick doesn't work. The med they're trying to drop, they spill it and they drop it on the floor.
I feel a little catch in my throat because it makes me want to just, run and hide.
Here's this lovely family and this lovely little kid that had inadvertently caused harm. Did I prepare this drug correctly? I was still having all these feelings of guilt and doubt.
Chances are you've done the very best you could.
I can still see some of the faces of the kids.
There must be a certain expectation that, well, you do this for a living, so you should be able to deal with it.
I just needed a little bit of time to clear my mind and someone to talk to.
You're just not expecting something quite so devastating.
No one comes to work thinking that I'm going to make a mistake today.
It just really stuck with me when I heard that woman say, "This can't be my little boy." it was just really sad.
We just need to make sure that we're taking care of our employees as well as our patients.
So many people have a story and they need to get it out.
I think having someone to help me see more clearly the events that have happened and to understand that I didn't do anything wrong.
You become a victim of it yourself, and that's hard to process if you don't have someone to go talk to about it.
Sometimes we're not able to recognize in ourselves how we're feeling. That's why we have the You Matter program. This program was developed to support staff 24/7. I think there's a lot of benefits from the Second Victim program. It's a peer support network, so it's really meant to be first line caregiver to caregiver support.
To have somebody at the moment or very close after it happened, I think it's a really big benefit.
Those that are offered a chance to work through their feelings in a supportive environment tend to do better. Overall, our culture is starting to change with this. People are starting to recognize others when they need a little bit more help. I've been approached several times already since this program has been up and running.
I have experienced more and more compassion about what we go through here at Children's.
The badge buddy that says You Matter identifies those of us who've been trained.
The Second Victim program means that there's someone here I can talk to and someone's shoulder I can lean on if I need it. And it also means that I could be that person for someone else.
So hopefully that just highlights a bit more about our program. So where we are now, we have now trained and worked with really over 70 hospitals around the country, and we've really enjoyed doing that and getting to share this information with those individuals. We do have a link to information about our program and how you can kind of access more resources from a training perspective. So I will turn it over to Brandon and look forward to taking your questions at the end of the session.
Yeah, so thanks, Jenna. So yeah, what I'm going to focus on is really, so how did we kind of manage to consolidate all these kind of well-intended various staff support efforts that were kind of going on and kind of make them into kind of a single process that we call the You Matter program here, as well as some lessons that we've learned here over the years as we formalize this. So if we think of our You Matter program, just a kind of visual outline of kind of how we see the pillars. So as Jenna indicated, it started with the Second Victim program. And so the You Matter program, we thought about like, okay, so if we really want to create a staff support program that ultimately has influence over the culture of the hospital. And this was actually quite important for kind of consolidating a lot of staff support programs, because what we did was we said, what are we ultimately trying to achieve here? Yes, on the basic kind of ethical area, we want to be able to support our team members who are struggling from just the impacts of them showing up to their profession, showing up to their career and providing excellent work. And excellent service. Okay, but we also want to create an environment that creates a culture of support, because we know that when people feel supported within the work environment, they tend to be much more engaged, they tend to be more collaborative, they tend to communicate more effectively, they tend to deal with conflict more effectively. Essentially, they tend to be much more productive and much more effective. So as Jenna was kind of going through this, developing this, and the team members were kind of developing this program and selling this to our executive leaders, there was both the right thing to do piece, but there was really a business argument at this as well in terms of helping achieve our mission of best outcomes. And so what we ended up doing is we started looking at all these other different services being offered and saying, how can we kind of bring this under a single platform and program that can really just allow us to organize and execute on these services so much more effectively. So we had the Second Victim program in place. You can see over the green pillar there was the employee assistance program. That's actually where I came from. I was a staff psychologist on the employee assistance program, helping and assisting with a lot of these more higher level needs of staff, as well as serving as a consultant in this space. And then, as many of you are aware of the short center rounds, this was kind of something that we kind of developed because we thought, we wanted to be able to provide a place to talk about the kind of the human side of providing medicine that fit really well with the concept of a staff support program. We had critical incident stress debriefings that were occurring that was primarily the responsibility of the EAP, the Employee Assistance Program. I was actually doing those myself. What made sense for us to be able to kind of have that. I have some formalized internal processes with that. And then what we ended up doing is after there was real success and development and momentum here. So we got an executive sponsor. We really started to kind of show value. There was some additional research that Jenna was doing and surveys that were showing kind of the positive impact of support services were having on the overall wellness, functioning, and productivity of our team members. And so then after all of that demonstration of value added and how this was actually committing to this type of one team culture that we talk about here at Nationwide Children's Hospital, we really then started to get a formal budget and started to get a formal program around. This was a very, very big deal. It obviously, demonstrated kind of commitment from our senior leaders to supporting staff in a comprehensive way, which then allowed us to kind of bring in individuals like what we refer to here as the staff support clinicians that I'll talk about here a little bit more. And then the education side, this is the last pillar that just grew organically out of the work of individuals like myself, as well as the other staff support clinicians who are formal kind of clinical members of this team, which again, I'll talk about shortly. So we had the plane flying. Yay, we were feeling good about that. We got it off the ground. Yeah, there's the woohoo. We were feeling really, really good about this. And then, we got to the now what? This is what we mean about the maintenance phase of the work. We got the plane off the ground. Jenna and colleagues, just grassroots efforts. We're training peer supporters. We're gaining momentum here. Now, how do we actually maintain this type of program? And so these are some of the questions we asked. How do we keep our trained peer supporters engaged? How do we stay fresh in our employees' minds? What about kind of scope creep within this? What ended up happening is we were training these peer supporters, and I'm going to talk a little bit at the end about some of the basic things that we train them on. But how do we keep them engaged now? How do we keep this fresh? And so some of the key ingredients here from the maintenance is that establishing, and then this comes from, getting a formal budget. So as we're able to consolidate services, usually a budget can be formulated with that. You have to create some type of organizational structure around this program. So I'm the director of the program. I oversee it. I have other responsibilities here at the hospital as well, but we have a dedicated program manager. We have a dedicated administrative coordinator as well. That helps to kind of organize, plan, and set up various events that allows us to be visible, that allows us to stay fresh within our employees' minds so that we don't just become some type of program that some people hear about, but they don't really know, and they don't really know how to access it. We have been very, very focused on getting out in front, partnering with our peers over at organizational development to ensure that we're part of the employee orientation program. We get out in front, and I work very much with our senior leaders to make sure that various communications are going out, especially over the last 2 years with COVID, around how to seek support services. I'm very, very proud that our CEO, Mr. Tim Robinson, is often plugging our services in his Nationwide Children's Whole emails. And then creating these strategic partnerships along with our staff support clinicians. Real quick note here on the staff support clinicians. These are licensed master's levels mental health professionals. Most of them are come from social work background and training. And what we do is we strategically place them in areas within our hospital in which oftentimes there's higher levels of acuity. They serve as not only a go-to person for those local leaders within those high acuity areas. So think, NICUs, urgent care, emergency medicine, our behavioral health pavilion, which has a psychiatric crisis department there. But they also serve as the liaisons for the peer supporters who have been trained through our program that are actually work within those areas in a way that helps to kind of maintain that type of connection between the peer supporters and the leaders of the program, like myself. So here's our team, just to kind of show you. So there's me, the director. I'm the least important person on this slide by far. Christy DeVries, Tamikia Smith is our manager and administrative coordinator. They're working day in, day out, ensuring the healthy daily operations of our program. And then you can see we have our UMatter clinicians, which really allows us to be able to have this 24/7 on-call program. And then in addition, and something to kind of think about within your programs, if you don't necessarily have the budgeting for it, see if you can kind of look into different areas and you can hire on contingent staff members. So these are individuals who have a mental health background and training. They might be working in a mental health capacity in a different area within your hospital system or your organization. But maybe they would like to kind of take on some additional work here. They would like to work a few more hours a week to maybe kind of contribute in providing just a change of their type of services to supporting their staff rather than the patient population. And you can see that we have a group there. So we have over 14,000 employees. And as I mentioned, we continue to kind of have focus on momentum for this program. What do we do to stay visible, to keep things fresh, to maintain the energy? We have annual peer supportive celebrations. This is a way for us to kind of give back. We've effectively advocated for a budget to be able to provide gifts to these individuals. There's additional training that happens. There's an award that we kind of put out for our peer supporter of the year that we asked for nominations on. We have a UMatter Awareness Week where we really kind of partner with all our staff, including our senior leaders, to kind of get out there and demonstrate and our partners in employee recognition as well, to ensure that we're providing that recognition to our staff. I talked about the awards. We have quarterly peer supporter trainings to kind of keep them kind of updated. Think of that almost as kind of continuing education in a way, and then a quarterly newsletter. And then we had all this in place. And then as we know, the pandemic occurred, and then we had to say, okay, who moved our cheese, just like so many of us. So we had to kind of pivot and be agile and innovative, like so many of us during this time. So what did we do? You know, we have pictures from the past. We put them out there. We were visible. We used email. We used this platform that we're using right now, Zoom, WebEx, Teams, to get out in front. We started focusing much more on kind of providing essentially kind of settings for people to come and kind of get some mental health training and kind of check-ins for groups. It's almost kind of like quasi-group therapy, but it's kind of like a peer consultation / didactic instruction that's involved in there. Our staff support clinicians and our contingent staff support clinicians were the ones that were primarily facilitating this. And you know, we have our nice UMatter green. If you can see me right now in the video, there's my lanyard right there. We try to be very visible about this. And as you can see there, there's our COVID appropriate UMatter week. The top left corner is Mr. Tim Robinson, our CEO. We also have some of our staff support clinicians there. A couple pictures involves our chief medical officer, Dr. Rustin Morse, our chief nursing officer, Leanne Wallace. And just, you know, if you can see that we really utilize the visibility of our senior leaders, who are oftentimes very eager and willing to get out in front and show recognition to the employee staff. And in a way, they're able to kind of say thank you for your sacrifice. Thank you for the hard work. We know this has been incredibly trying times. And then also, though, it's kind of all comes within under the umbrella of the UMatter program. So essentially what our senior leaders are doing is saying that we know and recognize that you matter, and we want to continue to kind of showcase that as much as possible. What's fascinating about the UMatter program, really quick here, is that it's a grassroots program that ultimately developed and created incredible high-level executive support. Why? Because as Jenna outlined so well, we demonstrated the value through hard work and through research and surveying, showing the positive impact in terms of our ability to create a supportive cultural environment that leads to best outcomes. There's a picture of short center rounds. I talked about that a little bit already, so we don't need to go over that again. Go to the next slide here. I want to be kind of cognizant of our time. We do need to do more. We're never satisfied. We recognize that context and situation matters right now. We all know and understand the nursing shortage and the pain that so many of our clinical providers and colleagues are feeling right now. So as much as we want to continue to push for growth and development, we are at the meat and the potatoes of just trying to hold on and maintain the basics of our program right now, with doing a couple of little tweaking. So we are assigning newly trained peer supporters to a staff support clinician. This will serve as a liaison and source for consultation and questions and information. Peer supporters, what we found is after a couple years of them being trained, there's an attrition that occurs. They kind of become less and less engaged with the program. But if they have a dedicated person that they have an established relationship with that they can go to, that will send out various reminders and emails and resources to them that they then can reach out to for questions and support, because we never want any of our peer supporters to feel like they have to operate on an island. What we're seeing is that that's doing a much better job of maintaining that engagement. And then the creation of peer supporter leads. So we have some peer supporters who are just naturally taking on more leadership functions, being creative within their units, doing really, really great work. We decided we want to formally recognize this group. So in addition to the staff support clinicians, we have peer supporter leads and then the peer supporters. So you can see that some of this is a bit organic, that we're open and flexible of learning as we go. None of this was completely premeditated and strategically planned out. What we began was with a simple intent of wanting to do a better job of providing peer-based services to our colleagues should they be impacted by a negative event associated with their work. Next slide. And we're doing some updating. So the new ingredients of the updating, as you know, variety is the spice in life, but you don't want to make it the main ingredient. So as we're adding new things, we're thinking about stability but added value. This is where stress first aid is. I'm going to show a quick slide on stress first aid. We really focus on this is additional tools that we can provide our peer supporters, because what we heard from them is that the model and the training and the template is great, but the basics of tools and what to actually do is always helpful. Stress first aid has served as a nice complement to that. We actually asked our peer supporters to focus on the first 2 of the 7 C's, which is check and coordinate. Check in with your colleagues, plant that seed to know that that person matters enough that you are thinking about them and you're noticing when they don't seem quite like themselves. And then if they need help, or if they request for additional assistance, be aware of what those services are, those resources, so you can coordinate them. And then additional lessons learned here. Hire dedicated staff. Definitely resist the allure of new and shiny equals better. Stay focused on those meat and potatoes of what you're really doing. Sometimes we can become so eager to want to create such a robust program. You know, I would really strongly suggest not to try to create an instantaneous You Matter program like we have within your institution. You really want to allow this to develop in an organic way. We're only where we are today because we didn't force it. We allowed it to organically develop and allowed the need and the value that we're providing to basically show the way. Keep it simple and practical, and be aware of that boundary scope. So sometimes when you formalize a program, what ends up happening is people saying, hey, you're really good at kind of like helping people when they're struggling and they're dealing with an emotional crisis. Would you like to kind of be involved and around with a possibly difficult kind of termination of an employee? You can see how you start to kind of get some scope creep here. And we had to be thoughtful and work with other hospital leaders to kind of set those boundaries of what our program is designed to do, what our staff support clinicians are trained to do, and what they're not. And then, yes, you want to develop those opportunities. So real quick here, I talked about the strategic areas. We have partnerships. We do have employee health. We have employee recognition. These are separate programs, departments here. We have our Department of Inclusion and Culture. They all do various types of staff support work in different ways. What we do is that we are all on the same HR team, and we are myself and the directors of these different 3 areas, including employee relations, which is not on there. We're often meeting, interacting, communicating with each other to make sure that we're not duplicating efforts, but more coordinating it. So our growth, we started out with 3 FTEs, full-time employees in 2018. We're going to have 6.5, we have 6.5 right now. We're going to probably have 7.5, possibly 8.5 in 2022. So the key takeaways here: develop a proactive plan, even if it's just one person. As Jenna's story explained, this really started in the grassroots efforts of motivated people who are impacted personally by these experiences that wanted to do better and felt that as an organization we could do a lot better. Increase that dialogue. Now is the time to act. The great news is now more than ever, the receptivity and the awareness by senior levels within organizations of the absolute strategic need to invest in the mental and emotional wellness of our staff is there. You don't have to do a big sell job anymore on this. We used to focus so much on the data and the research and okay? And by now it's like basically you come in and say, we need to do more to support the mental and emotional well-being of our staff. It will lead to better outcomes and various metrics that, that we look at. Most of the time, it's pretty much, yeah, we agree, that is an important investment. So we're doing a great service in terms of reducing the stigma of mental health and seeing how actually creating a highly mentally healthy workforce, surprise, surprise, leads to less errors, higher quality of service, improved customer service ratings, and increased retention rates. So in summary, acknowledgement of needs, the first intervention, discuss this topic of second victimization, emotional awareness needs of staff, identify those opportunities, really look for those partnerships and motivated, like-minded individuals, particularly with strategic or clinical leaders in strategic areas within your system. Continue on the research. We're always happy to provide you the research that we have available to support you in your efforts. If you do have maybe perhaps a little bit more of a sell job to do, think of those strategic partnerships, those others kind of employee health, employee service areas that may make sense to kind of build some more collaborations on. Maybe we're not at the place right now to kind of create one single umbrella tent over these services, but by building those connections and reducing the siloing of that, you reduce the likelihood of duplicative efforts, and you increase the coordination, which over time may actually then develop into a formal kind of program. And then stay highly, highly visible. Email, digital boards, events, trainings, gifts, market yourself, partner with your marketing team. That's one thing that we did here and we continue to do here. We're always looking at our peers over at marketing to kind of help us in terms of how we can just get out in front, be visible, and be highly known. Because if people don't know about us, they can't take advantage of us, which means then they can't, obviously, most importantly, receive the benefits of the program. But in addition, they're not going to then be talking about the benefits of that program to their colleagues and peers, which thus increases the likelihood that they're going to take advantage of those services. Because at the end of the day, that's what we care about. And I will cease on my section here and I'll open it up for any questions. Thank you.
Okay. Thank you. Can we, thanks. There's one question that I'm gonna call on Thomas Ward to kind of unmute and ask his question.
Yes, ma'am. So I appreciate the presentation. Thank you guys for all the work that you're doing, because it's very important for sure. My concern is, obviously with COVID and even pre-COVID, levels of burnout when it comes to frontline staff. But looking at your peer supporters, because essentially they're dealing with negative and traumatic events on a regular basis, are you intentionally doing anything to support your peer support staff? And if so, what kind of controls or programs and services are in place to do that?
Thank you, Thomas.
Go ahead, Brandon, you want to speak to that?
Yeah, I'll hop in with that. Great question, Thomas. So one of the things that we focus on with all our peer supporter trainings is letting them know very clearly. I even asked them this in my training part. I said, can peer supporters need peer support? If you're going to be a trained peer support, well, yes, obviously so, right? And so one of the things that we do is really, really try to instill early on with our trained peer supporters to practice what you're preaching here. you too may experience some type of vicarious trauma, possible second victimization. The advantage of our program is that's why we have these dedicated staff support clinicians who primary focus is to be available for our clinical operations team. That includes the peer supporters. So they will reach out and they will access our staff support clinicians. They will actually then reach out to other peer supporters in their area. That's why we try to have all our peer supporters, encourage them that have a green lanyard. So it's a very visible. So if I'm a trained peer supporter, but I'm struggling and I'm able to clearly identify another trained peer supporter because they have the green You Matter badge buddy, I can then reach out to that individual. And if I can't find any of that individuals, I know that I can call extension 25005, where a trained staff support clinician will pick up the phone and be available to assist me.
Thank you. Does anybody else have any questions?
Real quick,
Steve?
what is your role title of your executive sponsor? Our current executive sponsor is Andrea Manning, who, oh geez, I don't know her full title, but she's a vice president.
Yeah. She's a vice president of patient care services. So she's one of our senior nursing leaders.
Great. Steve, you had a question?
Brandon and Jenna, thank you so much for a great presentation. My guess is that most of us are going, oh my God, 6.5 FTEs to run this. I'd be happy if I could get our hospital leadership to get us a quarter or a half of an FTE to try to do this. So one, can you break down some of what those FTEs are doing? And two, if you could say, and of those buckets, what is essential? So if we're going to go to our hospitals and say, hey, I need people to do X, and this program will not work if we don't have the folks to do this essential stuff, we're not going to get to the size that, you know, Jen and Brandon have right now, but we have to have the following.
Jenny, you want to talk a little bit about kind of at the beginning, kind of what you all saw was essential, because you know, you're very much there at that grassroots effort.
For sure. So we didn't have resources. And it's still not really a full piece of my job or FTE really dedicated to this. It was more of a group of individuals that had a passion for it. But I do think that identifying an individual, even if they are not a full dedicated FTE, but saying, you know, we're going to give this person X amount of time, you know, maybe it's a half of an FTE to at least kind of project lead getting this lifted off the ground. So even I think starting out with a 0.5 FTE, but that person's main focus of half of their job is to lead, get the right team together, because I do think initially a lot of this can be done at that level. Now, when you grow to the size where we are now, it clearly needs a lot more support, but that I think is important. So having a leader to take charge to kind of carry the mission forward and get the right group together. And then also, like, when it comes to training and rolling this out larger scale, like having some type of an administrative support coordinator in place is also very key to the success of this. You know, we trained a lot of people in setting up those trainings and coordinating the logistics of getting people where they needed to be and supplies they needed and training material. Yeah, like that took a lot more time than what I would have ever imagined. So I think starting out small with that type of support, but then growing larger and there might be some like existing safety professionals in your organization that have an interest and desire to this that would probably step into you know, working on a team that is leading this forward. But as the program grows, I think more resources are required.
And just to piggyback off of that, the single most important thing to really get this off the ground is to be able to establish a training so that people can sign up for to then become trained peer supporters. And in order to kind of create that training, so what we have now is that, and by the way, we at the hospital offer this as something for other institutions if they would want to, like, to essentially say, hey, we don't want to reinvent the wheel. we have opportunities to actually, be able to kind of become part of our training and then be able to take those resources and utilize them for your institution. So you just don't have to do everything yourself. Okay. So I just want to be very clear about that. When you're able to then establish a training, you need at least one person to help organize that. But then you can really look to kind of volunteers and, maybe subject matter experts that's already in your institution working in other areas, then maybe they'd be willing to volunteer an hour of their day, every other month to lead a specific section of that training. That's really kind of the basics of what kind of helps to kind of get us off going, because now you start to have more and more trained peers, and now you're really, really starting to get somewhere, which then maybe hopefully leads you down that path of being able to create a little bit of a higher budget. I hope that helps, Steve.
And then please, anyone, feel free to put your question in the chat or raise your hand, and we have a couple of people keeping an eye on that. I have a question. One of the things that I didn't hear you say, but I already know the answer, is where is all these resources located within your institution? Like, where are they housed? What department?
Yeah, so the UMatter program falls under human resources. And so I, as a director of the program, I actually sit on the senior human resources team. And so that's where we're housed. We have offices here, our staff support clinicians are sprinkled out around the institution because we have them strategically embedded in the areas, but we're formally under HR.
Thank you.
Prior, when we got started, we were getting funding from whoever would help us. So like the quality department and safety department actually would say, oh, we're going to buy all of your training materials for you. And pharmacy was buying badge buddies, and emergency services was buying other pieces. So like at first, just to give everybody a realistic depiction of what it looked like at the start, we were taking funding for whoever would provide support, which it was also awesome to see all of the different leaders from those different departments say, we see value in this, we're going to support this.
And our very first formal staff support clinician, Julie Davis, correct me if I'm wrong, Jenna, but her FTE was actually within the emergency services budget.
Correct.
So emergency services said, wow, we buy into this. This is so needed. We want to have somebody here just available to support our nurses, physicians, and therapists in emergency services every day. And you know what? We're willing to advocate for and find a line in our budget to be able to pay for this individual. Now, over time, what's happened is that person is now, that FTE has come over formally into our program, but it began within emergency services. So you can see how much that focus on building that professional network and those strategic partnerships is critical for being able to eventually get to a place where you have a formal program.
Are there any other questions? We've got 3 minutes, 2 minutes. So if you want to ask a question. I've never seen some of these people so quiet, so I'm a little surprised. Okay. Well,
I like to think of it as we answered all the questions so well.
You probably did. I just want to, I love that you showed us like the reality at the start. Like it takes time. And one of the things that I feel like you both really emphasized is building relationships within your institution is so important for this to spread and grow. And I think sometimes we want the quick answer. Okay, how do we do this? And there's nothing quick about it. You really have to put in the work on the ground to do that. And I want to see if you have any. Oh, Sue Scott's here. I want to see if you have any advice for anybody who thinks they should be at your point already. And again, how that 4-letter word we hate, time.
Yeah. So patience is a virtue, although I'm classically an impatient person, so I don't know if I practice that so well. And to your point, Linda, which I think is an excellent one, when you take the time to set up meetings and set up engagements with others within your institution, what you'll end up finding is that there's a lot of people who are incredibly motivated to want to support something like this. It oftentimes is due because their own personal experience or an experience of someone very close to them that they were impacted by. But you will find incredibly motivated, engaged individuals that if you can build enough of a stakeholder group, you really start to kind of create an excellent divide and conquer type of system there. So yes, really, really, if you're at the point of kind of, geez, I really want this to be much further along than I'd like to, you have to be patient with it. You have to take the time to build that stakeholder group and allow it to organically develop from that. Force feeding this too early, you run the risk of trying to bite off more that you can chew. You end up not adding as much value as you'd like to. Even worse, you might end up actually having some counterproductive effects of this. So that obviously doesn't actually help you here in the long run. So steps, one step at a time, process steps, but knowing that gradually we are getting into a better place than where we were.
Yeah, and I think one other thing to add too is that different leaders want different things when it comes to hearing about programs like this. So some people might really want all of the research and literature and looking at outcomes and stuff like that to get buy-in at the senior level. Other folks might want to talk to places that have established programs personally and get to know, like we've talked with various institutions. So I think it just depends, but engaging, having those conversations with folks, getting legal involved early on was key for us also, because a lot of programs get shut down before they even get started because legal has concerns versus with us, we partnered with them. We went to them first and said, help us design the forms we're creating, help us cut. They actually participate in one of our trainers in our training program for peer supporters. So I think that, engaging the right people is really important.
Thank you. Thank you so much, Jenna. I really appreciate it. And thank you. Yes, you guys, this was an excellent presentation. I really appreciate it. And I love your sense of humor too, because, you have to have a sense of humor in this work. And I love that you have it. And the thing, when you mentioned, getting all these things from different departments, all I could think is I ran a nonprofit for years. Oh my God, I would take money from anywhere, but like, I get it. And maybe that's a lesson I can bring to other institutions, is really try to see strategically where you can get things. So thank you so very much. We really, really appreciate it. And if anybody has any questions after, let me know and I can feed them to Brandon and Jenna. Thanks again for doing this. I appreciate it.
Thank you for having us. It's an
Yes,
honor.
thank you for having us.
Yeah.
Bye, everyone.
Bye-bye.
Thank you.
Thanks.
Bye-bye.
Bye-bye.